טוב, חברים, אנחנו רוצים לפתוח את הערב הזה, והפעם הזמנו את דוקטור בצלאל שנדוביץ לספר קצת מהניסיון שלו לגבי עדשות סקלרליות. לפני שבצלאל יתחיל לדבר, אני רוצה לספר לכם כמה מילים על דוקטור שנדוביץ, בצלאל. בצלאל בעצם ואני עובדים כבר למעלה מ-25 שנה יחד במרפאת עיניים של שערי צדק, כאשר הוא התחיל את דרכו בשערי צדק עוד כעשור לפניי, יחד עם ליונל אפשטיין שהוא ניהל את המרפאה, ועוד ותיקים אחרים. בצלאל הקדיש את מירב זמנו לטובת באמת המרפאה, ובעיקר הוא התמקד בכל הנושא שקשור במחלת הקרטוקונוס. תחשבו שאנחנו מדברים באמת על כמה עשורים, ורק תדמיינו איך המחלה הזאת נראתה לפני כ3 עשורים, ומה היו דרכי הטיפול אז, שזה ממש לא כמו היום. ובכל אופן, אפילו בשנת 97, כן, באלף הקודמת, הוא הקים קבוצת תמיכה לחולי קרטוקונוס. נכון, אז לא היה זום ולא היה אינטרנט ולא היה פלאפון, פשוט אנשים הגיעו מכל מיני מקומות בארץ למרפאת עיניים בשערי צדק, ושם הם חלקו את החוויות שלהם, שאלות וכולי, ובאמת הוא ניהל את זה ככה תקופה די ארוכה. ובנוסף בצלאל הקדיש המון לכתיבת מאמרים בנושא הקרטוקונוס, בנושא הקרנית, בנושא של עדשות מגע, מאמרים שהתפרסמו בג'ורנלים מאוד פופולריים של אופטומטריסטים כמו הקונטקט לנס ספקטרום, ובאמת הוא הקדיש את מירב זמנו. היום לפני כחודש הוא החליט שהוא רוצה להקדיש כנראה גם זמן למשפחה ולנכדים, ואולי לכמה תחביבים שלא היה לו זמן, אבל בכל זאת הוא ממשיך לתרום מזמנו אצלנו במרפאה, והוא עדיין מנהל את המרפאה של עדשות מגע, כך שהוא ממשיך להיות איתנו בקשר. ואני רק רוצה לאחל לך בצלאל, ואני מניחה שיש פה עוד הרבה אופטומטריסטים ותיקים שמכירים אותך, ויודעים מי אתה והניסיון שלך, ואני באמת רוצה לאחל לך הרבה מאוד הצלחה בהמשך, בפרק החדש של החיים, ושתהיה לך עבודה פוריה והרבה מאוד בריאות, במיוחד בתקופה הקשה הזאת. זהו, אני רוצה עכשיו לתת לך את הבמה, שתספר לנו קצת על הניסיון שלך. בבקשה, דוקטור שנדוביץ.
אוקיי, טוב, איפה אני? איפה השיר סקרין עכשיו? Okay. Why fit scleral lenses? I picked one of the interesting phenomena that occurs from time to time, the superficial fibroplastic nodule. As Ronit suggested, I am a clinical optometrist and contact lens practitioner in Shari Tzedek since some time many years ago. I acknowledge always my respect and thanks to my patients for choosing me to help them confront their visual adversities invoked by their corneal ectasias. The first contact lens was a scleral lens, and it was used for keratoconus and blown from glass. There are many reasons to fit scleral GP contact lenses rather than any of the other designs available, and the list continues to grow. I first became a great fan of these large lenses when I learned that corneal lenses could not be fit comfortably for the patient or his cornea when the surface of the cornea was very irregular. And my experience with gradually larger corneal lenses was also very ungratifying. As an example, I present this image, which I've always called as good as can be expected. This is a corneal GP lens on advanced keratoconus cornea. The patient was sort of happy, vision was tolerable, but I could not understand how his cornea remained healthy. When scleral lenses became available, he readily made the transition. Some years ago, I borrowed this slide from the website of Boston Sight, the developers of the Boston Pro's scleral device. As you can see, it showed then 40+ medical conditions warranting scleral lens use. Tonight, I would like to discuss with you a complication of keratoconus. To me, the functional definition of keratoconus says that the condition will cause a reduction in visual acuity secondary to increased corneal distortion, thinning, and scarring. Currently, stage treatment of keratoconus, when a diagnosis is achieved early in the development of the disease, begins with cross-linking the corneal collagen fibers to halt the progression. In a statistically significant proportion of treated eyes, improvement in corneal shape and function has been demonstrated. This is a bonus, not a promise. Second, as vision declines, glasses and then contact lenses are used to remediate vision loss. Third, scarring so significant that contact lenses no longer improve visual acuity is an indication for corneal transplantation. In this scheme of things, the importance of optometric care begins with the correct early diagnosis and continues through the stages of improving and maintaining good functional visual acuity with glasses and contact lenses. The application of contact lenses must be accomplished without sacrificing corneal tissue health. One of the complications that can develop through inadequate corneal GP contact lens fitting, aftercare and follow-up, or patient motivation in keratoconus is the proud nebula, or the superficial fibroplastic nodule. This image was printed in the British Journal of Ophthalmology in 1994. It's a slit lamp shot showing clearly the Fleischer ring. Shall I show you? The Fleischer ring here at the base of the cone and the highly raised proud nebula. The scar seen through a slit lamp appears as a grayish circular area. When fresh and painful, it will take up fluorescein and shine like a bright yellow-green lead. The epithelium is torn, and as in any corneal abrasion, the subepithelial layers of the cornea are stained. Another, and perhaps more instructive view of the lesion is seen as this anterior OCT cut. We'll see the slide again later, but for now, the point of interest is this bright yellow bulge. This is the in this anterior OCT image, a slice through an old re-epithelialized SFN. Geographically, we shall start with the lowest identifiable structure, the corneal endothelium, here. Next is the corneal stroma, the fuzzy blue area. With some magnification, both the membranes of Descemet and Bowman can be seen. The yellow bulge is the superficial fibroplastic nodule. For whatever reason, the algorithm of the OCT unit colored the scar tissue yellow. The 50 microns, more or less, of reestablished epithelium can be seen covering the scar. I want to spend a few moments talking about imaging. The classical OCT image that I presented tells the story best, but just for the sake of argument, let's say you wanted to see what your topographer would tell you about this scarred cornea. I've accumulated a set of 6 topography images of the same eye, captured from 1998 to 2013. In general, they are qualitatively instructive, but fail if absolute curvature values are required. Our patient first presented in 1998 as a consultation with our then head of department, Dr. Rosenman. She was already a seasoned contact lens wearer for keratoconus, and her left cornea had already a proud and eroded scar. The first topography image in the series shows basic keratoconus steepening to about 52 diopters. Secondly, there is this interesting little white area here. Where's my pen? I want laser pointer. This little white area right in the middle of the cone. The cone apex where the computational algorithm failed. It's the eroded apex caused by the flat-fitting contact lens. The third observation is a clinician's diagram that he probably used to educate the patient why a better fitting lens was required. This image shows the same overall keratoconus pattern, but note all of the irregularities. A fairly large flat area in the apex and other gray areas also within the pupil, which again show us the failings of the system to calculate curvature. A basic rule of topography interpretation is that when there's a flat area where you do not expect one, then someone has done something to that cornea. This is a tangential calculation by yet another device. The irregularities are easily appreciated, and again the blue splotch inside the otherwise steep area of ectasia shows us the area damaged by a history of poorly fitting lenses. By 2005, we moved onto yet another topographer. Here you can hopefully pick out that the cornea with the scar is the left image, while the right ectasia has a far more nicely rounded shape. On the day we acquired this image, the medical center was short on yellow printer ink. However, notice how boldly the flattened area of the scar is accentuated in relation to the rest of the cornea. According to my notes, when imaged, the patient had been nearly 2 days without piggyback lenses. One of our attempts to permit comfortable corneal contact lens aided vision with an SFN was to use piggyback system of a soft lens as a bandage and a carrier for the vision improving GP lens. Many patients succeeded quite well with the system. My only consideration was that the amount of oxygen access to the cornea. I suggested that the 2 highly permeable lenses would not be a sufficient oxygen barrier, and in fact, we saw very few cases of anoxia-induced neovascularization over several years. Also at this stage, I should like to address a burning question. How is it, doctor, if you have been improving the patient's contact lens fit, by this time some 7 years, that her maps still show gross irregularity in the area of the SFN? The answer is that they were still corneal lenses, sometimes with a soft lens under, and other times without. There was still some amount of pressure to the cornea, no matter how steep we designed the lenses. Towards the end, we were under 5 millimeters base curve, about 67.5 diopters, in an attempt to clear her nodule. The final map in the series was acquired in 2013. By then, we'd returned to TOMI imaging. By now, you have no problem identifying the scarred cornea. This is a perfect example of GIGO, or garbage in, garbage out. A technical term for too much shape change in too small an area, which becomes to the computer unintelligible. I would love to see what information our pentacam would deliver, but under the current pandemic conditions, the patient may not be back for topography updates in the near future. So what is this thing? Why is it there? The proud nebula, as we refer to the knob-like scar at the end of the cone in 1994, later became known more specifically as a superficial fibroplastic nodule. SFN more accurately describes what we see at the slit lamp and even more clearly with the anterior segment OCT. As keratoconus develops and the ectasia progresses, it's essential that if contact lens care is initiated, it must be carefully and effectively monitored. Once upon a time, the recommended fitting for keratoconus was close to flat K to achieve a minimal light-bearing pattern. This fitting proved to be very dangerous for many cones. Yes, it did provide sharper acuity than steeper fittings would, but if not steepened according to corneal changes, it would abrade the top of the ectasia. This abrasion would cause some pain, especially on the day after, when the patient would attempt generally unsuccessfully to apply his lens. After a few days, the de-epithelialized wound would heal, but the new cells were now piled a bit higher, and the surface of the surrounding than the surface of the surrounding healthy epithelium. The event would repeat itself until the patient would finally give up and come in for evaluation, explanation, and of course, the magic cure. By the way, the magic cure always implies, according to the patient, that the lens went bad. Universally, we found that the problem was the cornea, not the lens. But why did it happen? Well, I've concluded that the initial fitting philosophy was faulty. It was historical, but too flat. Good for vision, bad for the integrity of the apex of the ectasia. Lenses that required careful design and expense were seen by the patients to be too expensive to replace as often as needed. Too frequently, we substituted a cheaper option as a stopgap measure. Our best advice was no longer considered holy. Difficulties involved in scheduling and coming for eye lens evaluation. The inevitability of new lens fitting was disturbing, mainly due to the necessary expense. In their hearts, they expected to be needing new lenses and were just afraid to hear it said. Their reaction was either reappointing and reappointing and reappointing, or just plain missing appointments. Poor preparation by the patient by insufficient education and explanation on the part of the fitter at the time the contact lens care was initiated. SFNs, in my experience, have been the occasional result of many keratoconus contact lens fitters, probably worldwide. I cannot guess. I do know that the production of new SFNs continue. I've been required to refit several of these over the past couple of years, and I'm currently working with a couple of patients who support knobby cone tips even as I speak. The fitting challenges that cause the nodule. Primarily, the problem was that the offending lens was fit with a flat-on cone lens design. Secondly, when a more forgiving fitting, often somewhat steeper, was introduced, it came along with a reduction in sharpness of acuity, when fitting steep rather than flat. I have found over the years that the biggest problem in patient care is educating the patient. Explanations can never be clear enough or repeated often enough to make an impression. When the problem and the explanation is clearly in opposition to the demands and expectations of the patient, our job is very much more difficult. So why the problem? Explaining that a once satisfactory lens fit that became obsolete during lens use because of corneal changes is a big pill to swallow. Add to that the fact, obvious for many patient files, that follow-up visits were not kept by the patient, and very soon, not much else is heard, a defense mechanism. So the question comes from the patient, why should I have to suffer not seeing sharply? My old lenses gave me much better vision than these new and more expensive ones you've made. Cornea and contact lens optics are way beyond the scope of explanations to patients by this stage. We hope that time will heal and that the cornea will not require more than one remake of the lens. Interestingly, when I asked Professor Tzadok recently if these modules can be removed, he gave me both an answer and a proviso. The answer from the corneal surgeon was, certainly. The proviso was that the only contact lens that should be used afterwards would be a scleral lens. So maybe the solution to the problem is the modern oxygen-permeable computer-generated scleral contact lens. Since my first encounter with the SFN, I have gone the route of larger and larger corneal lenses, attempting to settle a lens comfortably without edge incisions or apical abrasions, unsuccessfully. For steep cones, for cones with huge curvature differences between opposite sides of the same cornea, simply for improved comfort, there is no invention to compare with the current wave of scleral lenses. Those available to us in Israel today are very good. It is true, though, that more advanced, shall we say, more forgiving designs can be had elsewhere. As I promised, we return to our classic image and the rest of the story. The two bold arcs above the SFN demarcate a scleral lens. The space between the raised scar and the lens is a saline-filled wet cell. Knowing that the contact lens is manufactured to a standard of 300 micron center thickness, we can estimate that the cornea from the endothelium to Bowman's membrane is not much more. The wet cell over the scar, around 75 microns, and elsewhere as much as 250 microns. I would rate this a good fit. Some of the advantages of a scleral lens in a case of advanced keratoconus with an SFN, well, there's a solution to all the problems engendered by corneal lens fits in the situation. The fit is improved both at the edge and the apex. Comfort, in all but, I would say, 2 out of several hundred cases, patients have said to me that I've changed their lives. Suddenly they can open their eyes and they can see comfortably. Lenses don't wander around any longer, neither on the eye nor flying off the ocular surface. And there are no trapped foreign bodies, but you must watch out for bubbles. Since the lens effectively produces a wet cell over the cornea, abrasion healing can occur while the lens is warm. The problems with the solution begin with the expense. It puts off many patients. The size, just looking at it, frightens some others. The application removal learning curve is very flat. It's very hard for some people to learn the technique, and for some patients, sadly, they never manage. There's a temporary loss of sharpness when going from a corneal lens, a flat-fitting corneal lens, to a steeper scleral lens that has a fluid cell. And very, very important, we must watch out for a low endothelial cell density. One of the signs of the low density are a loss of clarity of vision over a short time of wear. The test is really very easy. We do it in our clinic on a daily basis using specular microscopy. When there is a low endothelial cell density, the best advice given by research is to shy away from fitting sclerals onto eyes with endothelial cell densities less than 800 cells per millimeter squared. The low cell density inclines the cornea to edema, while even the best fit scleral lens of material boasting an extremely high oxygen transmissibility will do the same. An equation results which can induce edema, evidenced by refraction changes, reduction in achievable visual acuity, and in the words of a particularly sensitive patient, I feel something heavy inside my eye. Let's take a case in point. For comparison, this is a keratoconus cornea of a 20-year-old. Most of the cells have a very nice hexagonal shape. She's got a nice 2,600 cell count per millimeter squared, and her pachymetry is still a relatively reasonable 510 microns. Our patient, on the other hand, with a low cell count of only 837 microns, 50 years old, had a traumatized cornea, and what cells the spectral microscope was able to define are grossly irregular. Complicating the issue is the necessity of a rather thicker than normal lens, as the eye is aphakic from the trauma. He comes in regularly for checkups and shows the expected vision and refraction changes. So what can we do for him? Well, my first step is to reduce consecutive wearing time and suggest to him that he should use significant breaks between the wearing sessions. Recently, I was advised by our manufacturer that they now have access to a lens material with a far higher transmissibility. I may go to that in my next round of seeking better for my patient. And I may need to attempt a corneal fit, which most likely will not be acceptable, bearing in mind his aphakia. For the moment, see well, stay well, and thank you for your attention. If you have questions.
תודה רבה, דוקטור שנדוביץ. כעת יש אפשרות לפתוח את הדיון, מי שרוצה לשאול שאלות, מוזמן, בהחלט.
Well, that's good. Either it was perfectly clear, everybody's blown away.
בצלאל,
כן.
האם יש איזשהו ערך של cut-off של ה-cells density באנדותל של הקרנית, שמתחת לזה לא נתאים עדשות סקלרליות?
אומרים 800, ואני מרגיש שזה די גמיש. צריך לנסות, אם מישהו בא עם 900 או 1,000 והוא מראה שינויים כמו שמצאתי, צריך לשנות משהו.
Betsal, can I ask you a question?
Absolutely, David. What do you have to say?
The 70 microns difference that you found from the nodule to the tear lens layer, how long after the lens settled did you measure that? That's the first question. My second question is, how long did you wait before you fitted with a scleral lens and you stopped the RGP wearing?
You're talking about the image with the fit of the scleral lens in place.
Yes, when you did the OCT.
She probably
you took an OCT and you said it was 70 microns deep. How many hours after insertion did you do that measurement?
That was probably, she probably came in for a checkup.
Oh, so she was wearing the lens for the whole day. 6 hours, 7 hours.
Probably.
Yeah, this one, yes, that's the one. Yeah. You said here it was 70 microns. So she was wearing it for 6 or 8. You said 70 microns was there, and at the lowest point, or at the highest point, whatever you want to say.
Here.
There. That you said was 70 microns.
I estimate about 70 microns, yes.
Right, which is not much.
It's not much, but if I make
that's
this
why
much,
I'm asking how many hours. How many hours of settling was it?
I would say she came in for a checkup, and I did it then rather than doing on a day of a fitting, but I cannot remember.
Okay.
I say it's a good fit because if I go to raise this to 200 or 300 microns, then this will also raise.
No, I didn't.
similarly.
Yes,
So
no, that'll be too much. No, but that's why I think it's critical when you took that measurement.
Certainly.
That
Your
was
second
my
question
point.
was?
You said in this, when you gave the case history, you said this patient was wearing an RGP lens prior to fitting a sclera lens. Is that correct? How long did you wait? How long was she was the washout period?
There are two possibilities. One possibility is that she actually agreed to go without her GP or her piggyback for a period of time, might have been a week.
What?
Or the other option is that she says, no, it's impossible. I cannot go without my lenses, and I will come in wearing the lenses and take them off here. I don't remember what it was. I've worked in both situations.
But don't you think there's a difference when you do a topography?
Certainly. At some stage, I stopped taking topography of this eye because of the inadequacy of the medium.
Okay, I accept that. But so you based the fit on the OCT.
I based the fit on the OCT and the slit lamp.
Yes, and the lens thickness.
Yep.
And the tear lens thickness. Yes.
You've got the picture.
Very good. Thank you. Very good presentation. Thank you.
Thank you, David.
תודה רבה. אם יש עוד שאלות?
בצלאל, תודה רבה.
בבקשה. תודה לכולכם שהשתתפתם.
תודה רבה, יוצא מן הכלל.
ערב טוב, יעקב.
טוב. רונית ואבי, תודה רבה על הארגון, מעניין מאוד.
מאוד.
תודה רבה לכולם שהצטרפתם, ונשמח לראותכם בעוד שבועיים עם עוד הרצאה נוספת של מבט קדימה.
תודה רבה, יוצא מן הכלל.
תודה רבה לכולכם.
תודה לכם.
תודה רבה.
תודה רבה.
תודה, היה מעניין מאוד.
מאוד.